As with barbiturates, rebound increase in REM sleep may occur when they're discontinued. The number of total dreams stays about the same, but many of these dreams are reported to be very bizarre. There's also rebound in insomnia after long-term use. So these are short-term medications, 4 weeks or less. Some of the side effects, excuse me. As with many other medications, CNS depression, drowsiness, lethargy, headache, dizziness, major side effects. Other ones, they have a strong hangover effect. So if you're using these, like when I was administering the temazepam or Restorol, many of the people in the morning had what felt like hangovers to them, because I was helping them sleep but causing hangovers. However, it is less than in a barbiturate. It could be hypotension, respiratory depression. You can develop tolerance over time. Rapid withdrawal may result in similar symptoms, very much like alcohol withdrawal, with weakness, anxiety, delirium, grand mal seizures, which may not appear for several days after discontinuation. So again, we want to use these medications as brief as possible. We should monitor blood count and liver enzymes with these medications. Hepatotoxicity, anorexia, nausea, vomiting, jaundice, hepatomegaly or growth of the liver, abnormal liver function tests can be seen with benzodiazepines. Now there are drugs that increase the toxic effects. Now remember, earlier I said several hundred times the dose, the normal dose, is not lethal, but if you add other chemicals such as antihistamines, alcohol, profound, analgesics, anesthetics, tranquilizers, other medications, that will increase the toxic effect very quickly. Drug contraindications, drug allergies, severe respiratory disorders such as asthma, COPD, emphysema, pregnancy, and decreased level of consciousness. If a person already has decreased level of consciousness, we're not going to give them a benzodiazepine. And again, additive effects are seen with CNS depressants such as alcohol or opioid agonists. There's also decreased action with CNS stimulants. So if a person is using, for example, Adderall or Ritalin for ADHD, and you give them a benzodiazepine, you're not going to get the same results. If you give with barbiturates, you'll see an increased rate of excretion of the benzodiazepine. Cimetidine inhibits the enzyme that metabolizes benzodiazepine. So if you're taking cimetidine for GERD, your body can't metabolize the benzodiazepine, so you get the benzos in your bloodstream longer for greater levels and more effect. Some antidepressants can result to have a CNS effect, so you would need the alprazolam should be reduced by 50%. So the nursing implications, pretty common sense to what we're looking at. We're looking for, is the medication working? Is the medication causing adverse effects? So we're going to look for vital signs, especially respirations. We're going to look for sleep apnea, or periods of time when people stop breathing. People in this room, somebody in this room may have sleep apnea or know somebody with sleep apnea who wears a CPAP. If you're wearing a CPAP, or if you need a CPAP, maybe a benzodiazepine might not be the best choice for you. How's their cardiac function, their mental status, their age? Do they use alcohol on a regular basis? So what question will we ask? We're not going to say, we're not going to say, do you drink alcohol? Because that's pretty vague. A much better question is, How often do you drink alcohol, and what do you drink when you drink? Are you drinking beer, wine, or mixed drinks? How many a day? Or how often do you have to go buy a case of beer? Things like that. You want to have an idea of the overall, not just day by day. Well, yesterday I didn't drink anything. Well, that doesn't tell me anything, because the day before you might have drank a lot. We want to monitor liver and renal function. We're going to assess the CBC, or the complete blood count. We want to evaluate the half-life of the drug, and can the patient function in the morning? You know, if they go to sleep but then can't wake up in the morning, that's not good. And again, short-term only. Now, if a person overdoses on benzodiazepines, and we're seeing adverse CNS depressant effect, or adverse CNS depressant effects, such as decreased respiratory rate, we can give flumazenil or romazicon, and it antagonizes the benzodiazepines. So it's used for the management of intentional and accidental overdose. Remember that the people who took the 100 times normal, we can give them flumazenil, and it will reverse or act as an antagonist to the benzodiazepine. We're not chemically neutralizing the benzodiazepine, we're blocking the function of it. Flumazenil, romazicon is the brand name, is commonly kept immediately available for any unit that is administering benzodiazepines. Now, there are non-benzodiazepine receptor agonists. Lunesta is advertised on TV. That's the one with the butterfly. Sonata, Ambien, and Ambien CR, or Ambien ER. These are all Schedule IV drugs, meaning low risk for addiction and misuse. They have relatively short half-lives. Sonata has a half-life of 1 hour, which means when will it be out of the body? In 5 hours. Remember, 5 half-lives, and it's effectively cleared. So what do you suppose the side effects in the next day will be from Sonata if it's cleared in 5 hours? That's something we have to consider when administering medications. Ambien, there's 3 on this slide. That we have chlorohydrate or Noctec, Zolpidem is Ambien, and Zaloplan or Sonata. They selectively bind to the type 1 GABA receptors in the CNS. They have a very short half-life, and they should be used immediately before going to bed because there's such a short half-life. I mean, with Sonata having a half-life of 1 hour, if you take it at 7 o'clock at night and you're planning on going to bed at 10 or 11, it's almost out of your system. So take these right before going to bed. Chlorohydrate is not being used as much. It's being used more for it's being switched in favor of benzodiazepines, and the newer agents such as the Zolpidem and Zaloplan. Zaloplan and Zolpidem do not diminish stage 3 or 4 or REM sleep. So the recommended period for the use of these agents is 7 to 10 days, then with reevaluation if the person needs to use it beyond 2 or 3 weeks. Daytime drowsiness, generally not a problem with these agents because of their short half-lives. Does not cause rebound insomnia when discontinued. So, some of these non-barbiturates, non-benzodiazepines, such as Zolpidem, Zaloplan, and Lunesta. I'm not going to try to pronounce that generic, sorry. Short half-lives do not diminish stage 3 or 4 or REM sleep, and generally not a lot of daytime drowsiness. These are a good choice. How about side effects, though? Are there any side effects? Everything has side effects. You need lower doses for the elderly. CNS depression, drowsiness, lethargy, headache, dizziness, muscle, or joint pain. Now, I want to point something out. When you see a list of side effects, that does not mean everybody gets every side effect. Some people get no side effects. Some people get all of them. When you see a listing of side effects, especially when you get a medication and you open up that big sheet of paper with all that information, the manufacturers are required to list every side effect, every adverse reaction that has been reported, even if it's been reported only once. So that's why when we look at Davis, we look at the bolded and the italicized side effects and adverse reactions first, because those are the ones that happen commonly and are life-threatening. Everything else might happen, but only might. So just keep that in mind. We will review blood tests such as CBC and liver functions to look for blood dyscrasias and hepatotoxicity. Now, something that you have to remember, smoking enhances the metabolism of benzodiazepines. So you may need larger doses to maintain the effect in people who smoke. Important question, do you smoke? And then how much and when did you start? Those are just general smoking related questions. We'll always assess level of consciousness before starting the therapy and then while on the therapy, and we'll assess their ability to perform motor functions. Are they having any effects the next day? We are always on vital signs. We're going to assess for the sleep pattern. How many hours do they normally sleep? If a person only normally sleeps 6 hours, should we expect 9 hours? Probably not, unless they're sleeping 6 hours because of insomnia. Environmental controls, such as the temperature of the room. What do you suppose would be a good temperature to fall asleep in? Cool. You need a cooler temperature for your body to trigger the sleep cycle to begin. Lights and noise. Some people sleep better with a little bit of light. Other people need absolute darkness. So ask your patient, what's their preference? Personal note, my wife likes a little bit of light. I love absolute darkness. We compromise. We have a little bit of light. Noise, I like to have the sound of a fan on. My wife does not like the fan blowing on her, so no fan. That's okay. and that's okay, don't worry about it. Snoring. Snoring can indicate respiratory disturbances. Caffeinated products can interfere with these. Never, ever leave a medication at the bedside when you're administering medication. If your patient says, just leave it there, I'll take it later, don't. The most important reason for that is you don't know if they're taking it, and yet you're documenting that they took it. So you don't know. If they didn't take it, you document they did, that's incorrect documentation. Maybe they gave it to someone else. So a person needs to take it right in front of you, always. Some nursing diagnoses to consider: risk for injury, disturbed sleep pattern. We're hopefully going to treat that. Ineffective management of therapeutic regimen. We're not going to take these with alcohol or any other CNS depressant. We're going to avoid driving or other activities that require alertness. And do not abruptly withdraw doses. This is something that needs to be tapered off. Come back for the melatonin receptor agonists. No, we're just going to. We've only got a couple slides left. There we go. I'm back. Rosarum is also advertised on TV. It's a selective melatonin receptor agonist. Very short half-life, 1 to 3 hours, 2.6 hours. It's not even a scheduled drug. You can find that advertised on TV also sometimes, and in magazines. So it's a selective agonist for melatonin receptors. It's non-sedating. It's most used for treating insomnia characterized by difficulty with the onset of sleep. There's no limitations for duration of use. Side effects could be angioedema, abnormal thinking and hallucinations, dizziness. So what will we ask the people? What will we ask that person who's taking Roserum? Have you had any weird, unusual thoughts that you've never had before? Have you ever saw things that you thought maybe weren't there, or heard things? And they may see and hear things that they believe actually are there. So assessing hallucinations are best while they're happening. As with everything else, we're not going to take these with other CNS depressants. And if a person has moderate to severe hepatic impairment, we will also not use this medication. Teaching. As nurses, we will always be teaching our patients and their family. So we want them to keep a journal of sleep habits. What time do they go to bed? What time do they think they fell asleep? An idea. How many times did they awaken, and why did they awaken? Awakening because suddenly they woke up is different than awakening necessarily because they had to use the bathroom. Although that is another sleep disturbance that we need to address. Have they tried drug therapy? Have they tried non-drug therapies, such as relaxation techniques, meditation, yoga? We want to reinforce that sleep promotion is important. We want to abstain from alcohol and other CNS drugs because of the complication when we give medications. We want to make sure they understand that dependency can happen, and abrupt withdrawal is bad. That they shouldn't use machinery or drive. I always told my patients the largest machine they could use was a remote control for their TV, and that's it. Advise clients on the effects of caffeine. And do not keep these medications at the bedside. Just don't. So in the next section, we're going to come back and we're going to be talking about psychotherapeutic agents for emotional and mental disorders.